The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, good evening. Warm welcome to today's ISQua webinar on using big data to improve patient care. This webinar will provide an overview of big data techniques and then discuss 6 use cases which are likely to be helpful to use these approaches for healthcare organization in the near term. I would like to welcome back our today's presenter, Dr. David Bates, who is an internationally renowned expert in using information technology to improve clinical decision-making, patient safety, quality of care, cost-effectiveness, and outcomes assessment in medical practice. A practicing general internist, Dr. Bates is a Chief Quality Officer in Brigham and Women's Hospital in Boston, where he is also Chief of the Division of General Internal Medicine. He is a professor of medicine at Harvard Medical School and a professor of health policy and management at the Harvard School of Public Health, where he co-directs the program in clinical effectiveness. He also serves as medical director of clinical and quality analysis for Partners Healthcare. Dr. Bates' special interests include clinical decision-making and effective physician decision-making, particularly using computerized interventions. Also, quality of care and cost-effectiveness in medical practice and outcome assessment. He has published over 600 peer-reviewed papers, and he's presenting for you today. Just to remind you, everybody, that today's presentation will take approximately 45 minutes, and we will leave 15 minutes at the end for any questions that you may have. Please type your questions in the question or chat box provided, and we will pose them to David at the end of his session. We will be using polls during the session, and your active participation would be highly appreciated. Please enjoy the presentation, and over to you, Dr. Bates.
Thanks so much, Juliana, and it's great to have the opportunity to speak with you today. I'm talking about one of the topics that I'm most excited about, using big data to improve patient care. So I'll start by providing a little bit of backdrop, then I'm going to talk about what big data are and why they're important. I'll talk about big data in research. I'll spend most of the time on big data in clinical care, focusing on care improvement and key domains. I'm going to spend some time talking about mobile apps, which is another area that we've gotten excited about, and they're another source of big data. Then I'll tell you what our institution is doing. I think it's always instructive to look and see what somebody's actually doing on the ground around a topic like this, and then I'll wrap up. So this slide shows an international comparison of spending on health, and what you can see is that spending is going up, and the U.S. is spending far more than almost any other industrialized country, and that's become a big issue in the U.S. And there's a lot of focus on trying to improve efficiency. At the same time, the other dynamic that's happened recently here is that we've had a very big program put in place to try both hospitals and individual providers to adopt health information technology, and in particular electronic health records. And that's gone really well. People are adopting left and right across the country. And one thing that we worried about a great deal was, would this create disparities among hospitals? Would essentially the big hospitals move forward and other smaller hospitals get left out? And what you can see is that although the adoption rates are the highest in large hospitals, even critical access hospitals and small urban hospitals have adopted as well. So that's a good thing. Here all the boats really have come up. But what's less clear is whether these organizations that have adopted are really getting benefits from the health information technology that they're using. And I believe that one of the keys moving forward will be for them to start to use big data sorts of approaches. Now, one book on big data, which I would commend to all of you, is a book called Competing on Analytics, The New Science of Winning, which is by Thomas H. Davenport. And in that book, he goes through a number of examples. One of the examples he talks about focuses on Moneyball, which is both a very good book and a popular movie. And it focuses on a baseball team in the United States called the Oakland Athletics. What they did, which was really revolutionary at the time, was to focus on the use of data to understand which players would be successful, rather than looking at the usual sort of thing, which was how big and strong someone is or how hard they threw the ball. And the Athletics, over a number of years, had really remarkable success despite having one of the lowest payrolls in baseball. So that was fairly extraordinary at the time. The Boston Red Sox, which are the baseball team here in Boston, used some of those same techniques, and we were able to use those to win our first championship in nearly 100 years. So it was exciting to see that take place. Now, retailers are also using analytics very widely. You're probably familiar with what Amazon is doing, for example. But Walmart is one of the companies that has made very big investments in analytics. And they, for example, know exactly where all their products are at any given time. And they are able to track things really across the country. They use RFID tagging to sort out exactly what items they have and how much of them they have, and what's selling well in what location. Within healthcare, Watson has been perhaps the most notable venture. Watson is the computer that played Jeopardy and notably beat Ken Jennings in Jeopardy. And IBM has now turned Watson to a variety of different areas in healthcare. The first places that they went after were in cancer care. First, developing a partnership with Sloan Kettering around management of solid tumors, and then more recently working with MD Anderson in Houston around trying to understand how blood-related tumors should be treated. So how big are big data? Well, they're really big. A large novel is just a megabyte. That's the size of an ant. My first computer had 40 megabytes, and at the time I couldn't really understand why you would want anything bigger than 40 megabytes. But now, I'm not happy with multiple gigabytes on my cell phone. 1,000 times bigger is a gigabyte. That's the height of a short person, or the amount of information in one human genome. A terabyte is another 1,000 times bigger, which is an analog there is the annual world literature production, and it's also the length of the Auckland Harbor Bridge. If you go another 1,000 times up, you get to a petabyte, which is all the output in U.S. academic research libraries. And if you go even another 1,000 times up, you get to the diameter of the sun. So the amount of data that we have is just increasing dramatically. And this whole area has been heavily hyped. Here's one example of that from Nature. They had a major focus on science in the petabyte era. You probably seen or heard about the Apple Watch, which is built around the concept of bringing data to you at the in real time. And there are lots and lots of sources of this. The one that I'm the most focused on is the electronic health record, but there are tons and tons of other sources. So there's genetic and genomic data. There is imaging data. There are data from mobile devices. There's the number of wearables that are available is proliferating at an incredible rate. And increasingly, it's becoming possible to use even other types of data like satellite and video and audio data and to process that in very granular ways. And a couple of the types of data which I think may be most useful in healthcare are data from social media. and real retail data. And if you use those sorts of things, you can understand all kinds of things about people that it would be hard to understand otherwise. So this has a number of implications. First, lots of electronic clinical data are now available. That's true both inside the hospital and outside the hospital. Another development which is important in this area is that natural language processing techniques have come of age. And these are tools for looking at the information in the record that's text and processing it and understanding that. And then again, there are all these other data sources to link to, some of which I just referenced in the prior slide. Now, I want to go through a few big data concepts which I think are important. Most organizations will want to set up something called the data warehouse, which is a place to put your main data. What you then do is set up a variety of data marts, which are places that individual types of users can go to get at the data. And you might have, for example, a cardiology mart or an oncology mart, or a mart for the people in your management group. And this sort of architecture setup is greatly superior to the usual kind of setup in institutions in which there are multiple groups who each have their own completely separate databases. Another really important concept is the concept of data lakes. One of the challenges when you have multiple databases is it's not clear sort of how one relates to another. And with the idea of data lakes, what you do is have one big database, say of your hospital and electronic health record information. You might bring in another lake of data from, say, social media or retail data. And the point is that you don't have to have one-to-one links between those two entities to derive value from them when you use some of the techniques that are available to process big data. Another point is that data cleanliness is not as important as it used to be. Many of the techniques that are used in dealing with big data will tolerate a level of cleanliness that would have been problematic with some other approaches. There are many tools for going through big data. And many of these relate to data mining, but machine learning techniques in particular are especially useful for figuring out what relationships are within large data sets. One thing that comes up anytime you start to think about what technique to use is should you use a simpler algorithm versus a more complex algorithm? And my own experience in doing this is that you often get the same answers from simpler versus more complex algorithms. So it's not necessarily better to use more complex algorithms. It's harder to understand how you got to the answer with more complex algorithms, and often simpler ones work pretty well. Another important concept is validation. And what happens is that anytime you develop a model based on an individual data set, it reflects the idiosyncrasies of the data within that data set. So unless you validate the model in a separate data set, it can be hard to say how well it's actually going to predict. And it is a useful thing to go ahead and do some validation in most instances. So I'm going to stop here and have Juliana ask you a polling question. Juliana, can you please launch this poll?
Yes, David, no problem. So the poll, everybody should see the poll now, and the poll question stands as follows. Does the organization you work for have a plan around analytics? You can choose between the answers, yes, no, and not sure. So we'll give you 40 seconds, 50 seconds to vote, and we can see that 50% of our participants have already voted. So we will just give a couple of more seconds for the ones that are still trying to cast their votes. And we can see that the answers are been distributed amongst all number of options. So I'll give a couple of more seconds for everybody to vote. Okay, so we will close the polls now and display the results. You can see the results on your screen, and we have 40% of our participants voted for yes, 40% for no, and 20 for not sure. Over to you, David.
Thank you. So it sounds like people are at all different levels around this. So now I'm going to talk about big data and research. And big data is really going to be critical in many areas of research. There are a few examples from our institution include our ePath program. In pathology, big data is going to be increasingly useful. Immunology is another place where it will be extremely important, and there's a genomic pattern focused around immunology. Groups like these do need massive sets of organized data to be able to run their programs. And overall, big data is going to be essential for future and current approaches to solving many scientific problems. Collaboration is enabled substantially by being able to share large data sets, and this can help with some of the long-standing problems like phenotype association with both omics, that is genetics and genomics, and in imaging. And it's also an important strategy for gathering data for public health studies. At our institution, we've for a while had this entity called the Research Patient Data Repository, or the RPDR. This is a tool that basically lets anyone who has access to it sit down at their desk and ask questions like how many patients were seen at in our network who had heart failure, and you can then ask how many of those patients, for example, got readmitted after an admission for heart failure, and of those patients, what was their serum sodium level. That kind of thing you can do literally within a couple of minutes, and then if you want to get identified data, you have to put in an IRB, and you can then actually do an analysis. But this is enormously powerful for just testing out hypotheses and fishing around in data and figuring out do you have enough patients to ask a particular question. What this new entity will do is it will help link disparate islands of patient data, including both clinical and research data, across partners in our academic centers onto a common big data platform. So there'll be some public health data from Center for Medicare and Medicaid Services, biobank clinical genomics data sets, survey data, and like PROMS data and other types of data that we'll be able to link with this. One particular area that will be focused on this will be the Phenotype Discovery Center, and that will include some data that'll include the RPDR, but it will also be linked with a biobank portal, which includes data from lots of patients who've been willing to have their DNA sequenced. There's a mixture of authorization models. There'll be a variety of utilities which will let you make queries and do natural language processing and match controls and so on. And the idea is that this will make it much easier to do research. Okay, so this last year I published this paper on big data in healthcare using analytics to identify and manage high-risk and high-cost patients. And this is work that was sponsored by the Gordon and Betty Moore Foundation, and they brought together a group from around the U.S. and actually from around the world who were interested in analytics, and we got together and identified this group of use cases, which I think are some of the most important use cases in the near term, which can be used to improve care. And the 6 use cases we identified were high-cost patients, readmissions, triage, decompensation, adverse events, and treatment optimization. So what about high-cost patients? Well, high-cost patients account for about 5% of patients account for 50% of spending in the U.S. And the first step in managing this population is to identify this group. We've been doing that for some time at Partners. But what you then need to do is to manage them more effectively. And it turns out that many of the reasons that people end up having high levels of expenses is that they have issues in addition to their health issues. And if you want to do this most effectively, I think you need not only to have their electronic health record data, but also data about their mental health, socioeconomic status, marital status, living status, which we don't necessarily routinely collect. So one issue is collecting that data, and from the big data perspective, you want to not only predict who's going to be expensive, but then figure out how to manage them effectively. The way that we do this is we assign each of these patients who our primary care providers think will benefit from it a care coordinator, and that care coordinator works with them. But the care coordinators are also expensive, and they need to know what to do. And what I think big data can do for us is help identify specific actionable needs and gaps. Is this patient's issue that they need to be able to get to the hospital? They need transportation to the hospital. Is it that they have a behavioral health issue? Of the high-cost patients, about half have some sort of important behavioral health issue. And if you don't manage that, it's very hard to manage, say, their diabetes or their underlying health condition. The second important issue is readmissions, and the Center for Medicare and Medicaid Services has strongly incentivized reducing the frequency of readmissions. All organizations that are working on readmissions should use an algorithm to try and predict their frequency. The key differentiators here, I think, are tailoring the intervention to an individual patient. We had a set of things, a set of 4 things that we were trying to do for everyone, but we found that we just couldn't necessarily deliver on making sure that every patient who had been admitted got all 4 of those things. Individual patients, the key thing that they need is often one of those 4 things. If you can figure out what that is and be really sure that they get that intervention, you're more likely to be successful. It's also going to be important to monitor specific patients after discharge. Again, that's expensive, so you want to target that. But for example, congestive heart failure patients appear to benefit from monitoring after discharge. And you also want to try and ensure that a low rate of those who are flagged for intervention actually do get readmitted. So you want to be tracking how you did. Triage is another big opportunity. There are many inflection points in healthcare, and some of those are admission, evaluation for a specific issue like chest pain or shortness of breath, and then transfer. And for these, you need detailed guidelines that clarify how the algorithms will inform care. A couple of specific examples are evaluating newborns for early onset sepsis, and using emergency department composite scores to predict decompensation. Gabrielle Escobar, who's out at Kaiser, has done some very nice work showing that in both these instances, if people use algorithms, you can do much better at figuring out what care they need. Decompensation is also an important issue, and here the use case is monitoring patients, especially outside of intensive care units. It's possible to track lots of parameters with wearables or even, for example, devices that sit, say, between the mattress and the bed. And in one trial that we did, a device like that measured pulse, respiratory rate, and movement reduced the subsequent number of ICU days by 47%. Another area that I think will be important is looking at multiple parameters at the same time. This is especially true in ICUs. So if you look, say, at the blood pressure and the pulse and the respiratory rate all at the same time, and also, for example, the urine output, it'll probably be possible to do a better job at predicting who's going to do poorly than with what we're doing today. There's some work from the UK that shows that if you use multiple vital sign parameters simultaneously and then warn providers if they're not doing well, the mortality rate actually goes down. Here's a very specific example of from a company called EarlySense, which makes this device that sits between the mattress and the bed, and it incorporates multiple of the things that I have referred to. So it includes some monitoring, it includes a communication approach, and it includes some analytics. The way that this works is the device detects the patient's pulse, respiratory rate, and it figures out how much they're moving. Then some analytics is done in the background, and there's a short phase delay so that some processing can be done in the background to filter out the false positives and identify the signals that appear to be real. If a real signal is identified, there are real-time alerts which are sent to nurses and supervisors who get a message on their handheld device, and there's also a monitor at the central unit. They get this message, which here says that the patient has a high heart rate. They go in and can check out the patient, and then can take action if that's necessary. We did a controlled trial to look at this. It was done at a small hospital in Los Angeles. There were roughly 7,000 patients that were included, and here are the findings from the American Journal of Medicine. The length of stay in the unit fell 9%. The length of stay in the ICU for patients who were coming from medicine and surgery fell 45%. And the number of code blue events, or times that the patient actually had an arrest, fell 86%. So this is one early study from a small hospital. These results need to be validated, but I think they're quite suggestive. And another thing that I want to point out is that this kind of approach resulted in much less alerting than our usual sort of approach. So in this study, there were just 2.2 alerts for every 100 recording hours, and half of them resulted in nurse action. And in contrast, some of the more usual approaches that we use, like pulse oximetry, telemetry, and cardiovascular monitoring, have between 161 and 730 alerts per 100 hours, and a much lower proportion result in action. Overall, we need to do much better with with our alerting approaches and use techniques like this to turn off many of the false positives. The device I mentioned is far from the only sort of monitoring device that's being developed. There are a number of these that are really exciting. Another one, for example, is end-tidal CO2 monitoring, which monitors how much carbon dioxide the patient is breathing out. That has some issues because patients don't like to have the device that in their nose, and the non-contact monitors has some advantages. We did an economic analysis of this smart monitor, just looked at ICU length of stay and the pressure ulcer rate, and it looked remarkably good. These results were published in Critical Care Medicine in 2014. And in the base case, the break-even was within a half a year, which is really, really early for something like this. And even using conservative estimates, the break-even was within 3/4 of a year. Another area which I think is a potentially very fruitful area to focus on is the whole area of adverse events. So here we picked 3 which we think are targets that are important early on. One is renal failure, and the issue here is that changes in renal function are often apparent before the patient really decompensates. Renal failure is very expensive, and if you can head it off, make it less severe, there can, not only is the patient better off, but there can be substantial savings. Infection is another really important target. So here the concept would be to use combinations of vital signs and some related parameters to help identify patients who are infected or going to do poorly. And one example is using heart rate variability in low birth weight infants. This is something that I had, I had no idea that heart rate variability was associated with doing worse, but it turns out that it is. And often there are parameters that are buried in the data like this that you can bring out with big data techniques. Adverse drug events are another important target. And I think it'll be possible in the future to predict which patients are going to experience these using genetic and genomic and clinical information. Probably the first place that this will be done on a routine basis is in cancer care, but it could also be used soon in other areas like anticoagulant use and for antihypertensives. Another issue is diseases affecting multiple organ systems, and chronic conditions in developed countries are extremely costly. They account for roughly 70% of total healthcare costs. If we could predict a patient's trajectory, that could enable caregivers to target some of the expensive therapies to those patients who might benefit the most. For example, some of those with autoimmune conditions. We have lots of drugs now, like the biologics, that are very expensive, and they're often used in a relatively idiosyncratic way. So, for example, if we used biologics more effectively in patients with inflammatory bowel disease, we could probably reduce costs, and patients would be better off. Furthermore, there are increasingly registries that track patients like this, with one example being PCORNet, and those can be really useful because they hold longitudinal data over quite long periods. And what you want to know is, let's say, if you use a biologic early on in a patient's course of disease, does that help them out in the long term or not? That's been a hard kind of question to ask. Most of the studies have been very short term so far. There are a variety of new sources of data, and one of these is mobile applications. The number of mobile apps has just absolutely skyrocketed, and what's happening over time is that the number of these apps and how much they're being used is going up rapidly. So this figure suggests that early on, physicians might suggest apps. Eventually, we may get to the point where there's systematic use of mobile apps in healthcare. And for patients, for example, who have high blood pressure, one of the first things a provider would do is to make a recommendation about that they use an app to manage their healthcare. And where we're probably eventually going is that these apps will be fully integrated with healthcare, and they'll be something that we use on a routine basis. The patient uses their app, the data comes back to the electronic health record. We're still a little ways from that, but this is how this could potentially progress. I'm going to tell you about one specific app, which is one called Ginger.io. And this is an interesting app. They use big data techniques to try and improve mental health. And what they do is they collect data from your smartphone about your use of texting, phone, and location. And when they analyze that, they're able to predict how a patient is feeling. Turns out that development of depression is closely correlated with patterns of use. And what they've done is, for example, to target patients who are undergoing bypass surgery. It's well known that among patients who have bypass surgery, some of them get quite depressed afterwards, but it's been hard to figure out who those people are. With this sort of approach, you can figure out who is not doing well, and this is the sort of thing that can enable providers to intervene earlier. Obviously, there are many privacy issues here, and patients would need to consent to this, but it works remarkably well. So next, let me tell you about what we're doing with analytics at the Brigham, at our institution. And this comes back to the polling question. I think every organization ought to develop an approach and a schema for what they're planning to do. We do have a strong culture of leveraging data for decision support, and we have a tool that we call the Balanced Scorecard, which at the time that we developed it, we were quite proud of. It includes data from both our physician organization and our network. It enables other analysis throughout our healthcare center. There is some two-dimensional reporting, and there's some canned reports on what happened. There are a few interactive analysis capabilities, but it has a number of shortcomings. We don't have very much data from outside the hospital, and it's hard to tell what's going on for, longitudinally. You can't do too many interactive things, and our leadership tells us they find it a little bit hard to use. Where we want to be able to go is to enable predictive modeling. So we want to be able to leverage both internal and external environmental data to predict the future, to be able to do things like aim at appropriate staffing levels given what we expect the future state to be. We want to be able to do complex statistical analyses and identify practice patterns and variations. Here's some example projects. So one thing we would like to be able to do is look at our census in a variety of areas, but we've had particular fluctuation in obstetrics to try and predict what will our census be and what our patient volume needs going to be. We're, as I mentioned earlier, trying to target our high-risk care coordination interventions. This has been very effective for us. We've been able to reduce the costs of care for our patients who are high risk, but that program is expensive, and the more efficiently we can use those resources, the better off we'll be. We'd like to cover more patients than we've been able to cover, and if we could be more efficient, that would help us do that. We want to target patient decompensation and leverage multiple pieces of physiologic data to identify when a patient's health is getting worse or when they're about to suffer some sort of complication. We would like to be able to do a better job with managing chronic patients. We want to be able to look at provider care variations and analyze variations in practice patterns. We're increasingly being asked to consider bundled payment contracts in which we get a set amount of money to care for patients who are having, say, a particular procedure like a spine procedure. And we've been reluctant to get involved in those because we haven't known exactly what our costs were, but analytics could help us with this. And then finally, we're going to redo the balanced scorecard and improve the user interface and the functionality, and try and make it easier to do queries, and ideally make it so that multiple people, including people who are not analysts, could do these queries. So here's an example of obstetrics status without predictive modeling. You can see there's a lot of variability, and we have these significant gaps from our budget. Even though our patient care services are trying to use do both use weekly and seasonal trends to flex staffing, but they have trouble to perfectly align staffing with census and activity. And we did some analysis with predictive modeling and estimated that if they had these tools, they could have reduced that gap by 50% and might have saved $230,000 a year just on one unit. So what tools does an organization need if you're going to embark down on this road? Well, I think there are a few. One is that you need some tools to actually be able to do analytics, and there are many companies now that are springing up that will sell you those tools. You also need registries, which are tools that let you look at populations of patients, for example, with diabetes and with heart failure, and look across those populations to figure out how you're doing and how you're managing them. You probably want to start figuring out what your approach is going to be with monitoring devices, and I think all of us will be using many more monitoring devices. These should be selectively in particular populations, but for example, in patients with congestive heart failure, it's been shown that if you do some monitoring after patients go home, you can manage them more effectively. And then you need a data warehouse that basically houses the data that you have, and that needs to have the capability to have a variety of marks for various users. This slide just shows our overall care redesign program, and we have many different strategies for redesigning care. Some of these focus at the population level, others focus at episodic care, and then many are in the middle. But for example, we are taking all our primary care practices and converting them to patient-centered medical homes. We think that will be more efficient. Our high-risk program, which I've referred to earlier, has really been very effective. At the other extreme, we have an approach in the hospital called patient progression, and there what we've tried to do is we've identified nurses and physicians who are responsible for each individual unit. Before the issue was there were often units where no doctor really felt responsible for how people in that unit were doing. Now we do have somebody, both a nurse and a physician, who are responsible, and what we do is get them data on a regular basis about how we're doing. We've also built tools for the physicians who are outside our network called Physician Gateway that helps providers figure out how we're managing their patients and helps communicate with them. And then we have a whole array of things that are in the middle. We have some that are aimed at better engaging patients. We have a large effort that's focused on patient affordability. We are trying to make sure that patients get the care that they need at the appropriate site. We have a tertiary care hospital and a secondary care hospital, and what we want to do is try and make sure that patients get the care that they need at the least expensive site. For many simple things, we want to direct them to secondary care as opposed to the tertiary hospital. And we have an array of things focused on trying to reduce readmission rates. With safety in particular, I think there are some specific wins. Some of the earliest ones will be predicting decompensation, visualization of who's doing well and not well, for example, in places like the intensive care unit, in the emergency department. If you have a big screen that lets you look at that and tell it at a glance who your most sick patients are, that can be really helpful. Predicting the trajectory will be very useful. Predicting specific types of adverse events will be useful. And I think big data will be very useful for pharmacovigilance. There's some early data suggesting that if you look, for example, at social media data about medications, you can predict much earlier than with our traditional approaches which drugs are really causing problems. So data and analytics, I think, in the future are going to be absolutely foundational in every care redesign effort. And you know, if we can use our analytics well, we'll be able to do much more. You know, for us, we already have a pretty good picture of what care is like in the hospital with a balanced scorecard, but the tools could be much easier to use. And we've had little data from outside the hospital. We're planning to make a major investment in that area and to bring in the data from outside so that we can manage patients. We're now at financial risk for patients after they leave the hospital as well as inside the hospital. So to wrap up, clinical data are now nearly ubiquitously available in most developed countries. The levels of adoption of electronic records in the U.S. are now around 80%, both in the inpatient and the outpatient setting. In developing countries, there are also some exciting use cases for big data, but they differ from those in developed countries. It involves, for example, bringing together data from cell phone records and so on. You know, I think that most organizations still haven't figured out how to best leverage these data. 40% of the people who were polled today said that their organization didn't have a plan. I think even those that have decided that they want to do something probably, you know, mostly haven't figured that out as well as they might like. And every organization is going to need to invest. I do think that big data approaches are going to result in many insights in both clinical care and research. I believe that some of the examples that I gave are the ones that will most likely bear fruit early on. There'll be a number of others. Another point I'd like to make is I think that novel sources are likely to provide the most marginal improvement. So if you look at where we are in doing a little better, for example, bringing in data from social media and from mobile devices, you know, that will make the biggest difference. And I'll just close by making a few predictions and give you some thoughts about implications. I think this could be as transformative as the internet. That's especially true as we move to the Internet of Things, in which a variety of things that are in our environment will send data back. Many of our societies are aging, and if we can monitor patients after they're home, we can probably they'll probably do much better than they are today, and they'll be able to stay home longer and do better, with less help. This will have many privacy implications. I'm concerned that true privacy may no longer be possible. We do have to get appropriate safeguards in place. I will suggest that a killer app for me has been the new Google Maps. I don't know how many of you use it, but we had a winter last year in which we had an enormous amount of snow in Boston, and I used Google Maps to figure out how to get home every day. It would take into account all the traffic in various places, and it suggested to me, I've lived in where I live now for 25 years. I took 30 new routes to get home last winter. I never would have thought of that without having information from this. And the power of Google Maps is that data from everybody that's using it comes into Google, and they then use the algorithm which was built originally by Waze to suggest to you which way to go. The future, I believe, will involve linking multiple of the things that I've talked about. So data from social media, mobile data, using big data approaches in the cloud, and then a variety of sensing technologies, and that will make our world look a lot different than it does today. And I will stop there and take questions.
Thank you, Dr. Bates, for this exceptionally informative and really a treasure of information presentation. We do indeed have a number of questions, and we will start with them. So the first one is coming from Mohammed Jaloli, and he's asking, do you think that data mining can bring new implications in some diseases?
I think there's no question that data mining will bring new implications in some diseases. Now, when you do data mining, it's hypothesis free, and most of the things that you find are things like, that Coumadin makes the INR go up. They're things that we already knew, but you do find some new things as well. Sometimes they are just false positives. They just are statistical anomalies, but many new insights have emerged from doing things like that. I think this will be very useful, for example, for identifying new adverse events, and we'll find a number of associations that we just did not know about. You do have to be careful, and you have to validate.
Thank you, Dr. Bates. The next question is from Patricia McKernan, and she's thanking you for this very informative presentation. Her question is as follows. Many organizations still have a portion of the records in paper format, and clinical and business data often remains in separate systems. What advice do you have for such organizations in order to effectively use data to evaluate and improve outcomes and costs?
So that's a great question, and it's certainly the case that often these data are in separate places. If you do use the sort of approach that I'm talking about and take the data and put it in a central data warehouse, which again I think everyone will want and will benefit from, you will get many new insights. So if I were in that situation, the first thing that I would do is to invest in a single data warehouse, and then to develop a set of approaches for enabling people to query it. We've showed that for example, it's exceptionally useful to be able to have both the lab data and the medication-related data in a place where you can move back and forth pretty easily, because there's just so many interactions between those two sets of data. But there are many other interactions between for example, the managerial data and the clinical data, and you want to set up an architecture and approach that lets you look at both at the same time.
Thank you, Dr. Bates. The next question is from Antonia, and she is thanking you again for this very informative and current presentation. And she's wondering how to manage legal aspects and confidentiality, integrity, and security involved in managing the big data.
Yes, so that's an important and complicated question, and in essentially all countries, there are at least some rules about maintaining confidentiality. It will be important probably for nearly all countries to update their rules and regulations about this, so that their policies catch up with this new world. You know, and then organizations need to set up approaches that let patients opt in if they want to have more of their information shared, or opt out if they want less of their information moving around and accessible to multiple parties. The tricky thing is that once you start to have all these various types of information, essentially everyone does become identifiable, and new policies have to deal with that.
Thank you, David. The next question is from Kalada Richard from Nigeria, and he thanking you for addressing a very topical and emerging issue. His question is in holding physicians and nurses accountable for the performance of their units. Do you make adjustment to the severity of the cases?
So we do make adjustments for severity, and that clearly it's important to do. Mostly we compare them with themselves, and we say, so how are you doing compared with how you were doing, a month or a few months ago? So that we make more comparisons with them themselves over time, as opposed to comparisons with other units. There are times when we have units that are pretty similar, but that's one way of managing the severity question.
Thank you, Dr. Bates. The next question is for Farheen Shaikh, and it's, I think, further development of the question on the confidentiality and integrity. So he's asking, so does collecting data via application, via app, also requires IRB approval?
So does it require IRB approvals? I mean, sometimes it does, sometimes it does not. If you're using it in a study, then you have to get IRB approval. If you're using it for routine clinical care, you do not need to get IRB approval. You do need to make sure that the patient opts in to allow their data to be shared.
Perfect, thank you. The next question is from Shuganti, and more clarification is needed. What is data cleanliness?
So data cleanliness is what percentage of the data is accurate and what percentage is wrong. If you look at any individual data element in a system, roughly, typically about 5% of it is inaccurate. That percentage is substantially lower for things that are used a lot, like the gender of a patient tends to be more accurate than that. But for things like that are not used very much except, for example, by people who are doing research or working on quality, is things like race. And race tends to be less accurate. One question has been, do you have to have completely clean data to be able to do meaningful analyses of quality or costs? And historically, we've focused a lot of time and effort on trying to make the data as clean as possible, and that's still a laudable goal. But with many of the newer big data techniques, they're more tolerant of having dirty data than the older approaches. So you don't have to wait to put something like this in until your data is clean, because it's never going to be clean.
Thank you, Dr. Bates. And next question is, what is the accuracy of device data? How do we lessen the false positive and false negative?
So a lot of the data that are collected from devices and wearables today is actually really good. Companies have to do quite a bit of testing before their device is approved to demonstrate how accurate it is, and typically it's accurate at a level that is much higher than the data accuracy is for many other items that we use all the time. For example, we record whether or not a patient has RALs or crackles on their lung exam. Well, the accuracy of that's inter-observer reliability around that is not very good. Similarly, for the presence of edema, which is something that we record all the time, inter-rater reliability is pretty poor. But for these devices, they typically are accurate at levels of, say, 10 to the minus third, which is much higher than we're used to for many other clinical parameters.
Thank you, Dr. Bates. We have a lot of questions on privacy of data, of big data. So I hope we have answered those questions, but if we didn't, please do come back to us. I will address a bit different question on validation from Iman Katie. And he's asking, how do we validate our data? How is sampling done for validation? If we collect, for example, data for a certain disease and the number of medical records are, let's say, 200, how many files do we have to validate?
So typically, what you do is either 1-to-1 or 2-to-1. So if you did 200 in your derivation set, you'd have 100 in your validation set. It's even better if you have 200, but you can get a very good sense with 200 in the derivation set and 100 in the validation set.
Thank you, Dr. Bates. The next question is from Kasidi Afanvi, and he would like to thank you for this highly informative webinar. And his question is, how do we deal with cybersecurity?
So that obviously is a very big and complicated question, and it's something that we need to continue to pay a lot of attention to. I think what the most important thing to do there is to try to do our best to keep up with the current approaches, and to put state-of-the-art techniques in place. The current things that are most helpful is to have passwords that change with a certain periodicity, and it's easy to tell, for an individual password how secure it is, and then in many instances we will want to go to using what's called two-factor authentication, which is not only a password but also, say, an additional piece of information, which you can often get, say, through your cell phone via text. So you both have to enter a password, and you then use a second factor with this approach via cell phone being kind of the most easiest and most practical.
Thank you, Dr. Bates. We have time for maybe 1 or 2 questions, and then we will wrap up our Q&A question session. So the next question is from Ahmad Bilal, and he's thanking you for the mind-changing presentation. And in his organization, the major obstacle to implement the EHR is coming from the medical staff. So from your expertise, how should the organization solve the problem or try to solve the problem?
So, in many organizations, the medical staff has been concerned about making this transition. But I think it's the sort of thing where, well, once you make a transition, there's no one who wants to go back. Um, um, and the key is to get the organization to the point where they're willing to make the switch. It really is like using a horse and buggy versus using a car. No one wants to go back to the horse and buggy, even though some people express nostalgia for it. And the conversion is a difficult time. Electronic health records still don't do all the things that we would like them to do, and they could be substantially better, but they're getting better at a very rapid clip. And I think you need to work with your staff to get them over the hurdle. There's a set of principles to follow around doing that. It's really important to have strong support of the clinical leadership and the administrative leadership, and to tell everybody that we're going to go in one direction. If you do that, things should go well.
Thank you, David. We would like to have David for another answering your questions, but unfortunately we will have to let Dr. Bates go to attend to his patients. So I think we will wrap up our Q&A session for today, and hopefully we will see David delivering further webinars for us. To spread Dr. Bates' message, you're invited to tweet about this session. So please use either at ISQua or at debate safety when you're tweeting. Just to remind everybody that the recording of this webinar will be available on the ISQua website within the 24 hours of the actual live webinar taking place. So please do share the information with your colleagues. I would like to thank Dr. Bates for joining us today for this session and presenting us with this valuable information that we would not otherwise have so condensed in 45 minutes. And I would like to thank you all for active participation and for joining us today. Have a good day or good night, depending whenever you are, and goodbye.
Thanks so much, Juliana. Bye-bye.